Welcome to the deep dive. Today, we are plunging into a medical mystery that's, well, it's both ancient in its impact and incredibly modern in how we diagnose it: myocarditis.
Right.
We're talking about inflammation of the heart muscle itself. Now, if you're like most people, when you hear inflammation, you might immediately think of, I don't know, a swollen ankle and a simple fix.
Yeah, something straightforward.
Exactly. But the reality is that myocarditis isn't one disease, it's this massive spectrum of conditions. They have profoundly different triggers, cellular mechanisms, and most critically, dramatically different outcomes.
That's a crucial distinction we have to make right at the start. I mean, when we talk about myocarditis,
Yeah.
we have to recognize that huge range of presentation.
Okay.
It can present acutely, meaning symptoms flare really rapidly, usually in less than a month. Sometimes it's just a matter of days following a simple cold.
Wow.
Or it can be subacute, kind of creeping up slowly, or even insidious, where it masquerades as something else entirely.
Yeah.
And the outcomes, they're massive variable. For some patients, we see complete spontaneous resolution.
They just get better on their own.
They do. For others, it's a relapsing course that comes and goes,
Yeah.
or, tragically, a progression to chronic cardiomyopathy, which is, long-term debilitating heart failure.
But the profile of this disease is fundamentally changing, isn't it? It feels like myocarditis has stepped out of the shadows. We're seeing it and talking about it so much more than ever before.
We absolutely are. And that change is a direct result of technological advancement. I mean, the increased availability and just the routine use of highly sensitive troponin assays.
Those are the blood tests for heart damage. Yeah.
Exactly, the ones that detect even minute heart muscle injury. You combine that with the sophistication of cardiac magnetic resonance imaging, or MRI, and you're just dramatically increasing the recognition of even mild cases.
And I guess there's good news hidden in that.
There is. Here's the good news hidden in that increased diagnosis rate. These milder cases, they often have very good outcomes. We're simply much, much better at catching the inflammation early.
Okay, let's unpack this. What's driving this inflammation in the first place? Is it always an infection? When most people hear myocarditis, they immediately jump to viruses, especially after the last few years.
That is the traditional, and I'd say probably the most common view. And for acute cases, you're correct. They are most often attributed to an active infection, and predominantly viral.
But it's not the whole story.
Not at all. It is critical to emphasize the extensive and often overlooked role of non-infectious inflammation. This is not just a battle against microbes. We have these huge categories of non-infectious causes.
Like what?
Things like sarcoidosis, giant cell myocarditis, eosinophilic myocarditis, systemic autoimmune diseases, or even some of the incredibly powerful modern immunotherapies used for treating cancer.
So the body's own immune system, whether it's misfiring on its own or triggered by a drug, can be just as dangerous as a virus.
Precisely.
And beyond that immediate trigger, you mentioned that there's an underlying vulnerability at play here too, right?
Yes, that's really the cutting edge of our understanding. We now know there's a critical interplay between our genetics and inflammation that we are only just beginning to map out.
You mean some people are just built to be more susceptible?
In a way, yes. Think of the heart as being pre-programmed. Data shows that almost 1 in 5 patients who present with inflammatory myocarditis, they harbor genetic variants that are considered pathogenic for cardiomyopathy.
Wait, almost 20%.
Yes, it's a huge number. And it suggests that for many people, the infection or that inflammatory trigger hits a heart that was already, let's say, genetically predisposed to failure.
So that common cold or that seasonal flu might be something most people just shake off.
But in this subset of patients, it finds a structural weakness. That genetic predisposition angle is evolving so rapidly, and it's fundamentally changing how we view causality and, eventually, how we screen and treat people.
That sets the stage perfectly for our deep dive into the mechanics. Let's move into part 1 and look at the actual, the cellular physics of this disease. How do these invisible enemies, the infectious agents, actually harm the heart muscle?
Well, at a fundamental level, when it comes to infections harming the heart, we can really break the process down into 2 main categories.
Okay.
Either it's direct invasion, where the pathogen physically enters and damages the cell's structure itself, or it's activation of the immune system, where the host's own defense mechanisms launch an attack that just causes a ton of collateral damage to the heart muscle.
Finally, that brings us to phase 3, the progression to chronic disease. Is there a clear, established link between suffering a bad viral infection today and being diagnosed with chronic dilated cardiomyopathy years down the road?
This is where the field has changed the most dramatically and where we have the most uncertainty.
Oh, interesting.
While phase 3, the progression to chronic cardiomyopathy, has been demonstrated clearly in animal models of enteroviruses, the direct link between a definite prior viral infection and chronic cardiomyopathy in humans remains limited and, frankly, challenging to prove definitively. The entire field is reevaluating what we thought was a pretty straightforward causal relationship.
Why the scientific reevaluation now?
It's because of our improving diagnostic tools, specifically the cardiac MRI. Historically, if a patient developed heart failure and we saw a particular MRI pattern intramyocardial late gadolinium enhancement, which suggests prior inflammation or scarring,
Right.
we just assumed that scar meant the patient had suffered an unrecognized prior viral infection.
Yeah.
It was the standard explanation for idiopathic or unknown cause dilated cardiomyopathy. What's fascinating here is how the pathology shifted. We used to assume fibrosis meant prior infection, but now we see the strong genetic underlying component.
So the MRI was showing a scar, and the doctor would say, you probably had a bad virus years ago that you don't even remember.
That was the narrative for decades. But expanding access to genetic testing has shown that this same MRI scarring pattern, this late gadolinium enhancement, is also commonly recognized in genetic cardiomyopathy. And that just significantly clouds the distinction between a scar from an old virus and fibrosis related to an underlying genetic weakness.
So whether the heart failed primarily due to an aggressive virus or primarily due to a genetic predisposition that was then exposed by some mild trigger, the resulting permanent scar tissue looks essentially the same on a diagnostic scan.
It can, yes. And that is a profound challenge to how we approach and treat these long-term conditions.
It really is. It forces us to ask, was the patient doomed genetically and the inflammation was just the clock striking 12, or was the inflammation the true primary cause?
And the distinction matters. It really, really matters because one path leads to genetic screening and surveillance for the family, and the other might suggest chronic antiviral or anti-inflammatory therapies, which, as we know, often don't work for chronic lymphocytic inflammation anyway.
Let's pivot now to the immediate high-stakes situation, part 2. The acute clinical picture. Here's where it gets really interesting. The symptoms can mimic a massive heart attack.
Oh, well, absolutely.
So if you're a patient walking into the emergency room, the initial presentation can be terrifyingly similar, and doctors have to move fast.
They absolutely have to, which is why immediate differential diagnosis is so essential. Looking at the typical patient profile, acute myocarditis in adults typically occurs between 30 and 45 years old, and it's more common in men.
And women.
Interestingly, women tend to present later, usually over the age of 45, which may reflect different hormonal or immune protection mechanisms earlier in life.
And the patient usually feels like they've had a preceding illness, right? It doesn't just come out of the blue.
That's the classic prodromal stage. Patients often report nonspecific symptoms, typical of influenza, gastroenteritis, or an upper respiratory infection days, to a few weeks before the cardiac symptoms start. Over half of acute myocarditis cases are preceded by a fever.
So it's that period where you felt vaguely unwell, maybe thought you were getting better, and then suddenly your heart starts acting up.
That's the classic story.
What are the critical symptoms that raise the alarm and should send you to the emergency department?
Chest pain is, by far, the most common symptom, occurring in over 80% of patients. This pain is often chloritic, meaning it worsens when you breathe deeply, due to irritation of the heart sac.
The pericardium.
Right. But it can also be crushing and feel exactly like a classic heart attack.
Yeah.
Patients also frequently present with dyspnea or shortness of breath and arrhythmias, which can manifest as palpitations, racing heart, or even syncope, which is fainting.
And then there's the most severe outcome.
We have to acknowledge the most severe and tragic outcome: sudden cardiac death. According to autopsy series, it's diagnosed in 10% of previously healthy young adults who die suddenly. It remains a frightening possibility in a young, seemingly robust person.
How severe are these cases typically when they first walk in the door? Is everyone on the brink of death?
No, not at all. About 3/4 of acute cases present as uncomplicated. That means they have a relatively preserved left ventricular ejection fraction, the LVEF, which is a measure of the heart's pumping efficiency of 0.50 or higher.
So the pump is still working okay?
It is. They also lack signs of cardiogenic shock or severe ventricular arrhythmias, but that means about 1/4 of acute cases are complicated. These include an LVEF below 0.50, life-threatening arrhythmias, or clinical shock. And that clinical shock is the hallmark of what we call fulminant myocarditis, which is reported in about 39% of acute cases.
That combination of chest pain, changes on the electrocardiogram or ECG, and elevated troponin. That is the classic heart attack triad. How do doctors quickly and accurately distinguish between a clogged coronary artery, a true infarct, and a swollen, inflamed heart muscle?
That is the ultimate differential diagnosis challenge, and it's where all the initial management happens. Because the presentation is so similar, the first critical step is almost always coronary artery imaging, usually an angiography, to definitively rule out blockages.
So you have to check the pipes first.
You have to check the pipes. If the patient has chest pain and elevated troponin, but their coronary arteries are wide open, that scenario is known as myocardial infarction with non-obstructed coronary arteries.
And what percentage of those Minoka cases end up being myocarditis?
Myocarditis is subsequently diagnosed in up to 1/3 of those minosa patients. It's a huge proportion. And this is why cardiologists need to treat every chest pain case seriously, but also why they must proceed immediately to advanced imaging once a blockage is ruled out.
So let's look at the formal diagnostic criteria. We have probable myocarditis and definite myocarditis. What defines probable?
So probable myocarditis requires a new appearance of at least one core symptom, so chest pain, dyspnea, or arrhythmia, plus at least one supporting finding.
And those supporting findings are?
This could be elevated troponin levels, consistent ECG changes that suggest injury, or an echocardiogram showing decreased LVEF or a wall motion abnormality. And we also look at general inflammatory markers.
You mentioned general inflammatory markers, things like CPK and CRP. Can you define those briefly and why they're elevated?
Certainly, CPK, or creatine phosphokinase, is an enzyme that's released whenever muscle tissue, skeletal, or cardiac is damaged. So its elevation just tells us that some muscle is injured.
Okay.
CRP, or C-reactive protein, is a protein made by the liver in response to high levels of inflammation anywhere in the body. So when both CPK and CRP are elevated, it strongly supports the diagnosis of a systemic inflammation that's causing myocardial injury. It really bolsters the suspicion of myocarditis over another non-inflammatory cause of chest pain.
And what about the gold standard, definite myocarditis? That used to require a pretty invasive procedure, didn't it?
Traditionally, yes. Until the widespread adoption of modern imaging, definite myocarditis required a positive endomyocardial biopsy.
Which means taking a piece of the heart.
It does. A tiny piece of heart muscle was taken, usually via the jugular vein in the neck, and they'd look for a typical inflammatory lymphocytic infiltrate. Newer immunohistochemistry techniques help us identify the specific cell populations involved, which increases the sensitivity of these biopsies. But as we've said, the path to a definite diagnosis is changing dramatically.
How is modern medicine allowing us to get a definite diagnosis non-invasively?
The diagnosis can now be confirmed non-invasively when that typical symptomatic presentation is accompanied by the combination of elevated troponin levels and a highly specific pattern of injury seen on cardiac MRI.
So the MRI is key.
The MRI is absolutely key. It has to show evidence of two distinct things: myocardial edema, that's swelling in the muscle, and non-ischemic myocardial injury, all in the absence of any other known cause, like a tumor or drug abuse.
What does that classic MRI finding look like to the specialist? We hear the term late gadolinium enhancement thrown around.
Right, late gadolinium enhancement, or LGE, is how we visualize scarring or inflammation. It's the key. In a true myocardial infarction caused by a blocked artery, the resulting scar is usually subendocardial. That means it hugs the inside layer of the heart wall.
Okay.
But for inflammation, the pattern is different. The LGE pattern on the MRI typically shows a midwall location or an epicardial location, meaning the inflammation is in the middle or outer layers of the heart muscle. That midwall placement is a strong, non-invasive visual clue for cardiac inflammation, and it really helps distinguish it from an ischemic event, a blockage.
So what does this all mean? It means modern imaging allows us to get a definite diagnosis without always needing to go inside the heart?
That's the bottom line.
But when is a biopsy still absolutely necessary, given the risks of the invasive procedure?
A biopsy remains critical when a patient presents with features that suggest specific, severe, non-viral causes that would drastically alter the treatment plan and the prognosis.
So when the stakes are really high?
When the stakes are very high. We need the biopsy when there are clinical signs of aggressive disease, like recurrent ventricular arrhythmias, a sudden conduction block that requires immediate pacing, a highly elevated eosinophil count in the blood, or signs of a systemic autoimmune disease. These specific causes require specific, often high-dose immunosuppressive therapy, and you really need that tissue confirmation before you start those life-altering treatments.
Moving on to outcomes and therapy then. For those 3/4 of patients who present with the low-risk, uncomplicated version-preserved LVEF, no shock. What's the prognosis?
The prognosis is remarkably good. Spontaneous recovery is common without any specific therapies beyond simple measures, like diuretics to reduce fluid and nonsteroidal analgesics for the chest pain.
So Advil and water pills.
Essentially, yes. Follow-up imaging shows that almost all of these patients maintain an LVEF of 0.50 or higher, and the 5-year survival rate without needing a heart transplant is excellent, over 90%. This is the patient population that benefits most from our new early detection methods.
And for the complicated quarter of patients, the ones with reduced LVEF, arrhythmias, what's the management plan?
For those with reduced LVEF, they are managed with standard guideline-directed medical therapies for heart failure with reduced ejection fraction, or HFrEF.
The same drugs you'd use for any other cause of heart failure.
Exactly the same. Beta blockers, ACE inhibitors, etc. Within that complicated group, about 18% died or underwent heart transplantation within 5 years, so the risk is clearly higher.
And what about the paradox of fulminant myocarditis? It's the sickest group. They require mechanical support, yet they seem to have a surprising recovery rate. Wait, that seems like a total contradiction. How can the sickest patients have a better recovery rate than the merely complicated ones?
That is the fulminant paradox, and it's a brilliant example of how the body responds to injury. Fulminant myocarditis is characterized by this sudden, overwhelming cardiac depression, often requiring high-dose inotropic therapy or even mechanical circulatory support like an ECMO machine.
So they're on life support.
They are. But because the onset is so rapid and overwhelming, it suggests a massive, well-synchronized, and often self-limiting immune response. If you can keep the patient alive through that acute phase, which requires that intense mechanical support, more than 50% recover to near normal LVEF.
Wow.
They're incredibly sick up front, but the inflammation just burns itself out, giving them a strong chance of recovery if they survive that initial catastrophic period.
Whereas the patient with merely complicated myocarditis might be dealing with a slow, smoldering chronic inflammation that steadily damages the heart over years.
Precisely. The outcome is defined by the quality and duration of the inflammation, not just the initial severity. And crucially, what about routine immunosuppression for the presumed viral cases?
Right. Do you give them steroids?
The rule is clear. There are no clinical trial data supporting routine immunosuppression for acute myocarditis when the presumed etiology is viral. Treatment needs to be supportive unless a specific, non-infectious inflammatory cause is confirmed by tissue or highly specific imaging.
Now we're moving into part 3, where we dive into the specific culprits from the microbial world. Starting with the viral gallery, who are the usual suspects historically implicated in infectious myocarditis.
Historically, the picornavirus family of RNA viruses were the first and most widely implicated. These are primarily the enteroviruses: Coxsackie virus, echovirus, and poliovirus. These are the classic causes we studied in those animal models.
Okay.
Then you have influenza, another RNA virus, which is a recurring threat that causes episodes of myocarditis every winter and spring as its surface proteins change.
And what about the DNA viruses?
Oh, the DNA viruses, we often see involvement from adenovirus and the herpes viruses, including cytomegalovirus or CMV, Epstein-Barr virus or EBV, and human herpes virus 6, HHV6.
But I remember you saying we have to be cautious about linking some of these directly to long-term disease.
We have to be extremely cautious, and this goes back to our discussion about the genetic component.
How so?
Well, genome fragments of HHV6 and another one, parvovirus B19, are often detected in patients diagnosed with dilated cardiomyopathy. But here's the catch. They were also frequently found in the heart tissue of healthy control hearts from people who died of non-cardiac causes.
So their presence doesn't equal causality.
Not at all. It complicates their proven contribution to chronic cardiomyopathy, and it really underscores the difficulty of distinguishing between a trigger, a bystander, or an actual causal agent.
Let's focus on the most recent large-scale viral threat, COVID-19. What did the pandemic teach us about the incidence and mechanisms of cardiac involvement?
Oh, COVID-19 infection was associated with substantial and highly publicized rates of cardiac involvement. Based on broad population data during the height of the pandemic, the rate of myocarditis was estimated at about 150 per 100,000 people.
150. And what was it before?
To put that in perspective, that represented a 15-fold increase over the pre-COVID baseline incidence of myocarditis.
That is a staggering increase. And the demographics stayed consistent even with this novel virus.
Yes, pretty consistent with most other viral causes. The most common adult patients were young men under the age of 40.
And the mechanisms of injury were complex.
They were multifaceted, which made it so tricky. First, you had the cytokine storm, that massive systemic inflammation causing myocardial depression. Second, we saw evidence of activated immune cells and molecular mimicry triggering an autoimmune attack. Third, there was a protected entry mechanism via viral RNA containing extracellular vesicles.
And there was a fourth specific mechanism related to the vasculature, not just the inflammation.
Exactly. COVID-19 also caused prothrombotic endotheliopathy. The virus attacks the endothelium, the lining of the blood vessels, causing widespread inflammation and a pro-clotting state.
So it made the blood sticky.
Very sticky. And this led to microvascular damage, potentially causing tiny areas of ischemia and stroke, completely independent of the inflammation itself. So COVID-19 hit the heart via inflammation, immune confusion, and direct clotting effects.
Stepping away from viruses, let's look at a microbial enemy that is globally significant, Chagas' disease. This is not just a historical footnote, it's a current crisis in large parts of the world.
Chagas' disease is a major global heart problem that often goes unrecognized here in the U.S. It's the third most common parasitic infection globally, and crucially, it is the most common infective cause of cardiomyopathy worldwide.
Wow. And what causes it?
The agent is the protozoan Trypanosoma cruzi, and is transmitted primarily by the bite of the reduvid bug, often called the kissing bug, which is endemic to rural South and Central America.
I've heard of that.
And while eradication programs have been somewhat successful, it's estimated that over 300,000 residents in the United States are infected, though very few of those cases were actually acquired locally.
How does the disease progress in the heart over a person's lifetime?
It follows three distinct phases. The initial acute infection is usually silent in about 90% of cases, but 5 to 10% of people will present with acute myocarditis, characterized by this dense parasitic infiltration and myocyte necrosis, where the parasite reproduces inside the heart cells, forming these pseudocysts, which then rupture and cause diffuse damage.
And then it enters that silent stage that can last for decades, where the patient feels fine, but the damage is still occurring.
That's the indeterminate phase, and it can last 10, 20, even 30 years.
Mm-hmm.
This progression was once thought to be purely a secondary immune activation, but we now recognize that persistent low-level parasitemia, the actual presence of the parasite in the blood, is the major determinant of ongoing inflammation and progression to chronic heart failure.
So the bug is still there, doing damage.
It is. Furthermore, the parasites cause damage by depleting parasympathetic neurons in the heart, leading to nerve damage that severely complicates the conduction system.
And the final, chronic phase, leads to a very specific, aggressive type of heart failure. What specific clinical clues should signal that a patient's heart failure might be due to Chagas?
The profile is quite specific. T. cruzi should be considered in any patient from an endemic region who presents with specific conduction system disease. Clues include sinus and AV node conduction block, but especially the finding of an isolated right bundle branch block.
Okay, that's a big one.
It is. They also have frequent and dangerous atrial and ventricular arrhythmias, which are often the cause of sudden death. And their dilated ventricles are typically highly thrombogenic, meaning they form blood clots easily. They also sometimes develop aneurysms, particularly at the apex of the heart.
That specific combination of conduction block and an apical aneurysm is a massive red flag.
A huge red flag.
So what is the treatment for Chagas' and how does it relate to that stage-based progression you described?
For acute myocarditis, antiparasitic drugs like nifurtimox or benzimidazole are essential and highly recommended. These are also often advocated during that indeterminate phase, especially for children, women of childbearing age, and adults under 50, to try and clear the parasite load before permanent damage sets in.
But the distinction in treatment for chronic disease is critical, right? That's the paradox.
It is absolutely vital. A large multinational trial showed no benefit for benzimidazole in patients with established chronic heart failure from Chagas cardiomyopathy.
Why not?
The reason is that once the heart has reached that chronic stage, the damage is irreversible fibrosis and nerve damage. The parasite is no longer the primary problem. The resulting scarring and structural defects are.
So what do you do for them?
Those patients need standard HFrEF therapy, often with pacemakers or defibrillators due to the high risk of arrhythmias. And sadly, their survival rate is significantly lower than for other forms of cardiomyopathy.
That distinction between treating the parasite in the indeterminate phase versus treating the resulting damage in the chronic phase is paramount. Giving a potentially toxic antiparasitic drug to a patient who only needs standard heart failure medication is just unnecessary risk.
Precisely. Once the heart is permanently damaged and fibrotic, the antiparasitic drug won't reverse the damage, and its toxicity outweighs any potential benefit.
Moving on to toxin-induced damage by bacteria, Most bacteria cause injury through widespread sepsis, but diphtheria is a specific, potent example of direct toxin harm. How does Corynebacterium diphtheria specifically attack the heart?
The mechanism of the diphtheria toxin is highly specific and frankly lethal. The toxin interferes with protein synthesis in host cells by inhibiting something called elongation factor 2.
So it shuts down the cell's factory.
It completely shuts down protein production. And this is particularly devastating to metabolically active tissues like the heart. In the heart, this especially affects the conduction system, the electrical wiring, leading to rapid blockages and failure. Cardiac involvement is tragically the most common cause of death from the infection.
And because of that specific rapid mechanism, treatment has to be immediate even before laboratory confirmation.
Absolutely. The treatment priority here is speed. Clinical suspicion is sufficient indication for the specific antitoxin, which should be administered rapidly. This urgency means the antitoxin administration is often prioritized even over confirmatory lab testing or the antibiotic therapy used to kill the bacteria itself.
And one final infectious agent that is tick-borne, Lyme carditis.
Lyme carditis is caused by Borrelia burgdorferi, a spirochaetal myocarditis. It's often accompanied by the classic rash and arthritis, but the carditis most often presents as conduction system disease.
And the good news?
The good news is that, unlike diphtheria, the pathology here is often reversible. The conduction block resolves quickly, usually within 1 to 2 weeks, with appropriate antibiotic treatment. It's only very rarely implicated in chronic heart failure.